All right, we're starting back on chapter 28 just to talk a little bit more about expiration. It says quiet expiration is normally a passive process. All I really have to do is relax after I take a breath for that pressure to change in my lungs and my thoracic cavity, and air just kind of comes out. Remember, when I breathe that I increase the pressure in my lungs, but I decrease the pressure in my thorax. And when I relax and I breathe out, there's decreased pressure in my lungs and increased pressure in my thorax. All right, and I have to have that pressure difference, or things would just pop when I try to take a breath. So, and also when I take a breath in, make sure you understand what the thorax actually does. I actually have a little bit of a thorax kind of expands a little bit. And my ribs are able to expand a bit, but that doesn't happen as we get older. Things try to get really firm and they don't have much movement anymore in my rib cage. So older people are compromised because they can't take a good deep breath like you could when you were younger, because there's not expansion of the rib cage anymore. It also talks about elastic recoil of lung tissues. So as I take a breath, a lot of things get stretched out. And then as I let go and I relax and the breath leaves when I expire, then I have recoil. My lung tissues pop back into place the way they were. All right. I got something in my book. Also, it talks about expiratory muscles being used in forceful expiration. My husband's over here making noises. So when I breathe and I let go and I just breathe out, then I still have a little bit of air still in my lungs, and that's residual volume. We'll talk about that in a minute. But I can breathe out and then still keep pushing things out. And I can shut up, and I could keep pushing air out. All right, and we're going to talk about those more over in pulmonary volumes in a minute. I'm going to kill my husband. But it talks about a little bit about the muscles that I use, intercostals and abdominal muscles, if I was trying to force air out. All right. So, and that's important because I do have some people that have very labored breathing that I'll see a lot of use of inspiratory muscles and expiratory muscles. It just depends on how hard they're breathing. Let's see what else we need here. It says if we're using that forceful expiration, it talks about what happens with our internal intercostals. It says contraction depresses the rib cage and decreases the size of the thorax from the front to the back. Not really sure that you need that tidbit of information right now. And contraction of the abdominal muscles elevates the diaphragm, thus decreasing the size of the thoracic cavity from the top to the bottom. So all we're really saying is I'm using those muscles. I'm just making my thoracic cavity shrink this way and this way to force air out. Your next slide is pulmonary volumes. It talks about a spirometer. And a spirometer is an instrument that we use in the hospitals or with respiratory therapy that helps to measure different, the amount of air exchanged in breathing. Okay, and we're going to talk about those. In your book, it says, we take 500 milliliters, about a pint of air into our lungs with each normal inspiration and expel it with each normal expiration. Because this amount comes and goes regularly like a tide of the sea, it is referred to as tidal volume. Just your normal breath in and your normal breath out, tidal volume. The largest amount of air that we can breathe in one expiration by inhaling as deeply as possible is vital capacity. I've hit as much air as I can take into my lungs. So not just a normal breath, but all right, that would be my vital capacity. Tidal volume and vital capacity are frequently measured in patients with lung diseases such as emphysema or heart problems, conditions that often lead to abnormally low volumes of air being moved in and out of the lungs. Observe the area in 15.3 that represents the expiratory reserve volume. This is the amount of air that can be forcefully exhaled after expiring the tidal volume. So more that I can push out. Remember, I always said we could push more and more out. That would be our expiratory reserve volume. And then compare this with the area that represents the inspiratory reserve volume. This is the amount of air that can forcibly be inspired over and above normal inspiration. All right, that represents vital capacity. All right, next slide. Pulmonary ventilation continued. I about made myself dizzy with all this extra breathing. All right, we talked about those on the last slide, expiratory reserve volume and inspiratory reserve volume, so however much I can force out and however much I can take in. And there's the little picture on your next slide on 31, the picture that you have in your book that shows the ventilation volumes. You don't have to remember any of these volumes per se, just what the terminology is. Slide 32, ventilation continued. Homeostasis of blood gases. It says the homeostasis of blood gases permits the body to adjust to varying demands for oxygen supply and carbon dioxide. And you'll find this under the same title. It says, although we may take in only about 12 to 18 breaths a minute, that's something very important to remember. We are not moving, when we are not moving about, when we are moving about, we take considerably more than we do when we are exercising. Let's read that again. Although I may be only taking 12 to 18 breaths a minute when we are not moving, when I exercise, I end up taking quite a bit more. And that's because I'm using up more and I'm giving off more carbon dioxide, and I have to breathe faster to get rid of it and take in more oxygen. It says the reason our respiratory rate changes is because our body attempts to maintain a high set point level of oxygen and a low set point of carbon dioxide in our blood. So as we exercise and we're moving, we're burning more. Okay, we're giving off more byproducts in the body. It says when our cells use up oxygen during exercise, they draw more oxygen from the blood, reaching blood oxygen concentration below its set point. Likewise, cells release more carbon dioxide into the blood. So I have to breathe faster because I'm using up more oxygen, and I have to breathe faster because I'm giving off more byproducts or more waste that I have to breathe off. That's pretty simple. Brainstem control of respirations. It says changes in the respiration depends on proper functioning of the muscles of respiration. These muscles are stimulated by the nervous impulses that originate in the respiratory control centers in the brainstem. Anytime I hear the word control center, it's going to be in the brain. So there's a part of my brain that controls my respiratory muscles. The brainstem centers are influenced by input from a number of sensory receptors located in different areas of the body. These receptors can sense the need for changing rate or depth of respiration to maintain homeostasis. So all kinds of little sensors I have all over my body can detect if there's a problem. If something happens and it feels like I need more oxygen, then I'll breathe more. If something happens and it determines I'm holding up in too much carbon dioxide, then I'll breathe more as well. So take the person who has sleep apnea. And sleep apnea is a condition where we go to sleep, and for some reason, when that happens, if it wasn't for your brain, you wouldn't take another breath. Because you have building levels of carbon dioxide and lower levels of oxygen, your brain says, wake up, fool, you're dying. So you'll wake up real quick and take a breath. And this happens so many times for people with apnea that they may not even know that they're waking up. They may wake up long enough to roll over and not even know it. But these people are very sleepy during the day, lethargic, can't concentrate a lot because they're not getting enough sleep at night. Let's see here. Next slide. Ventilation continued. How much of this do I want you to know? Okay, we'll read under cerebral cortex control of the respiration. The cerebral cortex can influence respirations by sending signals that affect the function of the respiratory centers of the brainstem. In other words, an individual may voluntarily override the automatic brainstem rhythm of breathing and speed up or slow down the breathing rate. See, I can do that by myself. Okay? Or greatly change the pattern of respiration during activity. This ability permits us to change respiratory patterns and even to hold our breath for a short period of time to accommodate activities such as speaking, eating, swimming. Okay, while I'm talking, I'm not really taking a breath. The voluntary control of respiration, however, has limits. As discussed in later section, other factors such as blood carbon dioxide levels are much more powerful in controlling respiration. So it's just saying that my cerebral cortex is allowing me to make those decisions, but at some point, then my brainstem still takes over and takes the controls over. So if I hold my breath to go underwater, at a certain point, I start freaking out because my brain tells me I'm dying, and I try to get to the surface to take a breath. So I can hold my breath, but most of us can't hold our breath until we die. It really doesn't happen that way. And we can hold our breath long enough to pass out, probably, but then when you pass out, you start breathing. So that is a mechanism to keep you alive. Respiratory reflexes, it says chemoreceptors located in the carotid and aortic bodies are specialized sensory receptors that are sensitive to the increase in blood carbon dioxide level and decreases in blood oxygen levels, such as chemoreflexes. Such chemoreflexes can cause sense and respond to increasing blood acid levels. What you need to know about chemoreceptors is that they are adversely, well, I don't even think that's the right word. They are related. Chemoreceptors are what is related to what happens in your blood. All right. That's probably the best thing to remember about chemoreceptors. So if my chemoreceptors say, you know what, there's too much carbon dioxide in the blood, then I set off these big sensors in my mind for me to start breathing more to give off the carbon dioxide. And so that is part of what my blood tells me, all right? So the chemoreceptors in the blood. The pulmonary stretch reflexes. Stretch receptors in the lungs are located throughout the pulmonary airways and in the alveoli. Nervous impulses generated by these receptors influence normal pattern of breathing and protect the respiratory system from excess stretching caused by harmful inflation. When the tidal volume, the air you breathe in and out, of air has been inspired, the lungs are expanded enough to stimulate stretch receptors that then send inhibitory impulses to the inspiratory center. Relaxation of the inspiratory muscles occurs and the expiration follows. After expiration, the lungs are sufficiently deflated to inhibit the stretch receptors, and inspiration is then allowed to start again. So when it comes to stretch reflexes, all we're saying is that when I take a breath in, those stretch reflexes in my lungs say, okay, that's enough. And those reflexes send a signal to my brain saying, you've got enough air, now you can let go. Okay, so we don't overinflate our lungs on accident. Breathing patterns, you do need to know these. The terminology for these is important. Apnea is when I am breathing normally. Hyperventilation, rapid and deep respirations. Okay, this might be somebody who's trying to try to get rid of excess carbon dioxide. All right. Hypoventilation is when I'm not breathing, I'm breathing slow and shallow, okay? So, or I try not to do that shallow. It's just slow, shallow breaths. So, in hypoventilation, guess what I'm not getting enough of? Oxygen. Guess what I'm keeping too much of? Carbon dioxide. Dyspnea is labored or difficult respirations. So, if I'm running and it starts to become very labored and hard to breathe, I'm dyspneic. Apnea is when I have no respirations. Respiratory arrest is the failure to resume breathing after a period of apnea. All right, that is, okay. All right, the next slide is a little table that shows you what the waveform would look like in different types of breathing. Apnea, you've got that nice wave. Okay, like you remember we talked about the tidal volume, like a tidal wave. Hyperventilation. All right, hypoventilation, slow and shallow, not much going on. Apnea, I'm breathing fine, then I stop. And then Cheyne-Stokes respiration is where I do a little bit of a weird thing. And I usually see Cheyne-Stokes at the end of life. So I might go. All right, I usually say that when a person's about to pass away. All right, gas exchange and transport, pulmonary gas exchange. It says blood pumped from the right ventricle of the heart enters the pulmonary artery and eventually enters the lungs. And then it flows through thousands of tiny pulmonary capillaries and that are in close proximity to the air-filled alveoli. So we talked about this earlier, right? So when I've got my alveoli, and that's where the magic happens, right? And I've got the capillaries butted up against it with those very thin walls on both sides, then I can allow the air that I'm taking in, full of oxygen, to diffuse over into the capillaries and the waste from the capillaries to go back in so I can breathe the waste off. Very, very cool. It says external respiration or the exchanges of gases between the blood and the alveolar alveolar air occur in diffusion. Diffusion is a process of moving those particles. That is, substances move from an area of high concentration to a low. Remember, diffusion is the movement of particles. The amounts or concentrations of sub-blood substances are measured in terms of weight. Reporting how many milligrams of a particular substance are presented in 100 milliliters of blood is one example. However, the concentration of a particle, a particular gas, as in air within the blood, is exposed as the pressure exerted by that gas and is reported in millimeters of mercury. Much like, exactly like when we pump up a sphygmometer, a Joe Manganiello. All right, we pump that up in millimeters of mercury. It says, recall from chapter 13 that blood pressure levels are also reported in this way. Several different types of gases are present in both air and blood. The total pressure of all the gases present in the air or blood sample is, of course, the sum of the pressures exerted by each of the gases present. Because the pressure of the so-called respiratory gases, oxygen and carbon dioxide, in the air or the blood constitutes only a part of the total pressure present, their concentration is reported as partial pressure. Okay, and all we're saying there is that there's other things going on in there besides just oxygen and carbon dioxide. And that's about really all you really need to know there. Anything else in here? Systemic gas exchange. Systemic gas exchange means it's the gas exchange that happens out in my tissues. And that's the next slide. Let me see if there's anything else on gas exchange and transport you need. I do want to point out the hemoglobin combines with the oxygen producing oxyhemoglobin. And remember, I didn't get to do the blood chapter with you, but that goes back to hemoglobin being the red blood cells that carry the oxygen. Just wanted to point out where that comes into here. It talks about carbinohemoglobin, and we don't really need to know that right now. I think that's, it's very simple. It just breaks down the carbon dioxide into hemoglobin. It breaks out the carbon dioxide and the hemoglobin. But I don't think that's anything that we need to focus on right now. Definitely the carbon dioxide moves out of the lung capillary bloods into the alveolar air and out of the body. All right. So remember we just said that I've got my alveoli and I've got my capillary butted up against it, and my capillary is going to force carbon dioxide into my alveoli, and my alveoli is going to give off oxygen to my capillaries, and that way that they can be taken off into my system, out to my tissues, and then my alveoli can give off the carbon dioxide to be expired, all right? And vice versa for oxygen. Now, that's a little bit of a weird thing to think about. It's kind of a hard concept, so we can definitely talk about this when we do our post-conference on Monday. Nope. I guess when we do our post-conference tomorrow, because I'll have you Monday. Yep, so when we do our post-conference tomorrow and we talk about it, if anybody has any questions about this, please let's talk about it, because it's kind of difficult to think about. But it's almost just like the exchange in our blood, except for now we're exchanging it between capillary beds butted up against the alveoli and the alveoli himself. Okay, and the alveoli, of course, is what's taking the air through our upper respiratory tract, down to our bronchioles, through our bronchioles, down to our alveoli. So we've got oxygen-rich nutrients. We've got tons of oxygen in our alveoli, and we want to give it to the capillaries. And the capillaries is full of waste, and they want to give that to the alveoli. So there's an exchange right through those little tiny membranes, all right? And then my capillaries can send the oxygen back to my tissues for systemic gas exchange. And then my alveoli can transport back out through my respiratory tract those wastes. The next slide, 38, is the systemic gas exchange, and it talks about oxyhemoglobin. And oxyhemoglobin breaks down into oxygen and hemoglobin, all right? So the hemoglobin that's up next to the alveoli when we make that exchange originally, let's see if I can find this in the book for you. I don't even see it. Well, in the book, it talks about the oxyhemoglobin and the hemoglobin when it breaks down. I wish I could find it, though. I don't really see it. Let's see here. Systemic gas exchange in your book says the exchange of gases that occurs between blood and the systemic capillaries, that's all the capillaries out in your body, okay, at your tissues, is called internal respiration. As you would expect, the direction of movement of oxygen and carbon dioxide during internal respiration is just the opposite of that noted in the exchange that occurs in the internal respiration, when gases are exchanged between the blood in the pulmonary capillaries and in the air in the alveoli. Now, that's a little confusing because we're still exchanging both things. Okay, so what we're saying here is we'll keep reading. During the process of internal respiration, oxygen molecules move rapidly out of the blood through the systemic capillary membrane into the interstitial fluid and onto the cells that make up the tissues. At the same time, carbon dioxide molecules leave the cells, diffuse through the interstitial fluid, and then enter the systemic capillaries so they can go back to my heart through my lungs and be blown off. The oxygen is used by the cells in their metabolic activities. Trace these movements of blood gases for yourself. Diffusion results in the movement of oxygen from an area of high partial pressure in the systemic capillaries to an area of lower partial pressure. That you don't need to know. Don't worry about the partial pressures right now. Okay, we talk more about those when we get to med-surg. And that's about all I see. I still don't see the oxyhemoglobin, but it says oxygen moves out of tissue capillaries. Okay, this is just reiterating what the book said. Oxygen moves out of the tissue capillary blood into the tissue cells. Okay, and that's what we want. All right. So remember back in cardiovascular system, when I have oxygen-rich blood coming through my arteries, and they go to the arterioles over that capillary bed, it's oxygen-rich, and I need to give that oxygen to my tissues to survive. Right? Okay, remember? So what they'll do is they'll go out of the capillary bed and they'll migrate over to the tissues. And the tissues have used all that up and they've got waste to give off. So the carbon dioxide from the tissues, all that waste is going to move out and then migrate to the capillaries, all right, through the interstitial fluid, all right. So that's what we talked about before. And then the gas exchange in your lungs, then I'm going to be doing pretty much the same thing. So, I mean, it's just, I don't know how to say the difference here. There's not much of a difference. It's still an exchange, okay? It's still the exchange. If you look back up at the slide before, it says carbon dioxide moves out of the lung capillary blood into the alveolar air and then expired out. Oxygen moves then from the alveoli into the lung capillaries. All right, so we still have an exchange. I'm still blowing off carbon dioxide and I'm taking in oxygen. It just happens in my lungs here and it happens in systemic in my tissues out in the body. Okay, it says a little bit opposite, but when we say opposite, that's just the way that it's forced out through diffusion. Okay, and that's something we'll probably need to talk about together, I'm assuming. So we'll have a good discussion on that in post-conference if there's any questions about it. All right, exchange and transport of gases is your last slide. It's actually a pretty good picture to look at there. It says we've got inspired air that goes all the way down to my alveoli, and then we call that alveolar air. And then it runs over those capillaries butted up against the alveoli. My oxygen is given off from my alveoli into my circulation, and then CO2 is given off to my alveoli in order to blow out. All right. And then as we do that, you can see when I've got that good oxygen coming in, how it flows down through my arteries to my heart and through all the rest of my tissues. And then I have my exchange at the tissues. And it says in the opposite way, but again, it's still the same transfer. I'm still giving off O2 or picking up O2, giving off O2 to my tissues and giving off carbon dioxide to go back up to be breathed out. Okay. So when it says opposite, it's not really opposite. Don't get that stuck in your head. It's still the same exchange, and that's what you need to know that's important, okay? It's an exchange of waste and oxygen, okay? All right, that's enough for this lecture, and we can talk about it more in person tomorrow if there's any questions. I'll post this, and let's see what happens.